Howdy, I'm Dr. Adam Wright. I'm a hip and knee replacement orthopedic surgeon in Plano, Texas. Let me tell you about one of my patients. So this is a patient who owns his own business. He works in construction and he builds homes. He also has a long history involving his knees. Now both of his knees are worn out. They're both bone on bone and they're bow-legged. So he's walking around looking like he's been riding a horse all day. He's had ACL surgeries done on both of them a long time ago, and that's why it looks like a hardware store is left in his knee. So he's got screws and staples from different styles of doing ACL reconstructions. And an ACL reconstruction is a great surgery, but he was probably predisposed to arthritis, and then he had a bad injury, which makes that happen even more quickly. So I had a long talk with my patient here. He's got a lot of heavy activities that he's doing, and he owns his own business, so he can't be out of work for a long time. So we talked about doing knee replacements because he's tried everything else. He's tried therapy, he's tried injections, he's worked hard with braces, but he just can't get around. So we talked about doing surgery one at a time versus two at a time, and ultimately we actually decided on doing both of these at the same time. So what you're doing when you replace a knee, you're going in, you're taking out all the old arthritis, and you're putting in a new joint, a new bearing surface. Now a lot of people think you just cut up here and cut down here and you put a hinge in there. There's a little more finesse to it than that, and also it means that it's a little bit less invasive for the patient. So the way that we do this is we actually take about 8 millimeters or less of bone, kind of a sliver all the way around the femur, which is the thigh bone, and then just a flat cut on the tibia, which is the shin bone, again 8 millimeters or less typically, and then we replace what we take away with metal components and a plastic bumper in between. There are a lot of ways to get these to stick into bone. You can either cement them in place or do what I do pretty frequently, which is what's called a press fit technique, which means that the bone actually grows into the metal implant, meaning that it could last for the rest of your life. So for him, we did that, and there's lots of ways to do knee replacements. The way that I do it and the way that I think is best is actually using a robot during surgery, which sounds a little sci-fi and a little creepy at first, but when you realize how precise and how accurate this technology is, I can change exactly where I want a knee within 0.5 millimeter or 0.5 degree and get it perfect for each patient. So that's what we did for him. We actually did both of his knees in the same sitting, and he went home the next day. Now he worked a lot with therapy, but he had an excellent result and did very, very well. Let me show you his post-op pictures. So he went from having 2 crooked knees before to now 2 straight knees. He was able to go back to work very quickly, and he can bend and do squats and do everything he needs to do as he's walking around on the job. He's very happy with his result. Very quickly got off of narcotics, which is great. You know, I don't like people being on those very often, and I'd say most of my patients are off by about 2 to 3 weeks. You need it at the beginning. Surgery is painful. A lot of patients are only on Tylenol, but if you need that extra medicine, we'll get you on it, but we don't let you stay on it. We get you off pretty quickly. So he was up working with therapy. For the first 2 weeks, therapy comes to your house. They're working with you, making sure you're straightening your knee, bending it, and then after that, we send you to outpatient therapy. And I want that to be close to your house because I want you to be able to go. And so he went to a place that was close to him, went 3 times a week, got his motion back, started doing agility and strengthening exercises, and now he's back at work doing all the things he likes to do. So when you look at these x-rays, you can see the pieces to these. You've got the piece that goes in the tibia and the piece that goes in the femur, and they look like big hunks of metal. And from the front picture, they do look like that. But from the side, I'll show you it's not quite as maybe scary as it originally looks. From the side, you can see it goes around the corner and then just a slice on the top. And then another thing that people ask me is, well, what's this? Did you leave something in there? That's actually the kneecap, and it's supposed to be there, but you replace the back half of it because the back half usually has arthritis too. The front half has all of the attachments of your tendons, so we need to leave that. But the back half, if you don't replace that, can have a lot of pain. So I take care of that while we're in there. Thanks for listening. I'm Dr. Adam Wright again from Plano, Texas. If you have any questions, just put them in the comments.